In 2020, COVID-19 spread across the globe, and South Korea was no exception. To prevent the spread of the virus, the government enforced mandatory isolation for confirmed patients. At the same time, it tracked their movements to identify places with high transmission risks, such as restaurants and bars, and sent notifications to people who had been in those places, encouraging them to get tested for COVID-19. The government also used mobile location data, obtaining personal information from telecom providers to identify individuals who had been in the same area as confirmed patients. These notifications were not limited to those who had direct contact with the infected person or visited the same location. Even individuals who happened to be connected to the same mobile base station received alerts. This raises a key question. Is it acceptable for the government to collect personal information indiscriminately and without consent in the name of public health?
COVID-19 drastically changed nearly every aspect of daily life around the world. As the number of cases in China surged, many countries closed their borders to foreign travelers and enforced mask mandates and social distancing measures. South Korea implemented even stronger measures, such as publicly disclosing the movements and locations visited by confirmed cases, and requiring all people who may have come into direct or indirect contact with them to undergo testing. Confirmed patients were forcibly quarantined for 2 weeks in designated facilities. As the number of patients grew, home quarantine was introduced, and individuals who violated quarantine rules faced fines of up to $3,000. The concept of quarantine itself originates from the Italian word quarantina, meaning 40 days. This term has its roots in the Black Death that devastated Europe in the 14th century. The plague spread through fleas infected with Yersinia pestis, transmitted either through bites or airborne droplets from infected individuals. Between 1347 and 1352, the plague killed an estimated 20 million people in Europe, and around 100 million worldwide. The city-state of Venice, seeking to prevent the spread of the plague, required all ships arriving from abroad to anchor on an isolated island for 40 days before unloading their cargo. This practice became the foundation of modern quarantine measures. Throughout history, many countries have used isolation to control infectious diseases. In the U.S., patients with leprosy were quarantined in facilities in Hawaii and Louisiana. During the 19th century yellow fever outbreaks, many cities imposed similar measures. Cuba forcibly quarantined HIV patients in sanatoriums between 1986 and 1994. In Korea, leprosy patients were permanently isolated on Sorok Island. While quarantine is an effective public health measure, it can cause significant psychological distress and restrict individual freedom. For example, a nurse who returned to the U.S. after treating Ebola patients in Sierra Leone in 2015 was quarantined for 3 weeks upon arrival. Although officials treated her kindly and the quarantine conditions were comfortable, she reported mood swings, irritability, and emotional exhaustion during isolation. Then, is isolation of exposed individuals truly effective in preventing transmission? According to a meta-analysis conducted by the World Health Organization, quarantine measures can reduce the number of infections by 44 to 81%, and deaths by 31 to 63%. For this reason, active monitoring of both confirmed cases and potential contacts plays a critical role in outbreak control. Active monitoring involves tracking movement routes, assessing exposure risk, and determining the likelihood of infection. Common tools include mobile phone location data, credit card usage records, and CCTV footage. Based on this data, authorities notify individuals who may have been exposed and encourage them to get tested. As a result, even those who were never in direct contact with a confirmed patient, but merely shared a mobile base station, received these alerts. This leads to a central debate. Does the government have the right to collect personal data without consent during a public health crisis? Opponents argue that individuals have the right to control their own personal information, such as when, to whom, and to what extent it is shared. Even for reasons of national security or public health, indiscriminate collection of mobile location data is excessive. In many cases, exposure risk can be identified through direct interviews. without the need to access sensitive personal information like location data. However, supporters counter that in a rapidly evolving public health emergency, swift and decisive action is essential. They argue that if personal data is collected, only to the extent necessary, with procedural safeguards, such as post-notification to individuals, it can be justified. The MERS and COVID-19 outbreaks in Korea demonstrated how failures in the early stages of epidemic control can lead to catastrophic consequences. This is why governments may invoke public authority to access the personal information of infected or potentially infected individuals. However, such powers come with significant privacy concerns. They could be misused for surveillance or political purposes. Is it acceptable for the government to collect personal information without consent for public health purposes? Share your thoughts or opinions in the comments below.